morning, everybody. My name is Ryan. I work with the OLLI programs, and I'm filling in for Jen Howard. Today, we're going to do a webinar, the End of Life Considerations with Yasa. If you have any questions, please feel free to type them in the chat throughout the webinar. And then at the very end, I'll go ahead and read those questions. So if you want to go ahead and take it away.
Sounds good. Thank you, Ryan. And thanks everybody for joining this morning. I will make sure to provide my PowerPoint as well to Jennifer and to Ryan after the presentation. So I will go ahead and start with sharing my screen. So today I'm going to kind of do a overview of kind of like the progress of what I often see, like from home care to palliative and to hospice, and kind of key things to focus on when you're progressing or if you need the services. I wanted to touch base on kind of each one a little bit and kind of focus at the end on questions, myths about hospice, as well as questions that you may want to ask your doctor. So I kind of wanted to encompass all of it because we tend to see a progression sometimes with our services. I work for Trinity Health at Home. I always put in my presentations, I'm not the only organization that's out there. There are multiple organizations. So whoever you're comfortable working with or who you are working with, these are questions that you want to ask those providers throughout the progression. So just wanted to be able to kind of put that out there as well too. So I do a little brief point on home care, palliative, and then hospice. And then again, talking about myths of hospice, as well as questions that you want to ask your physician as well too. So quick slide really just talks about services that we currently provide. And these are very common with other organizations. So when you're working with an organization, whether it's for home care or hospice, you want to have those dialogues about what services are you able to provide myself or my loved one as well too. The next slide really talks about, if I'm going too fast as well, feel free to slow me down. I try to go pretty slow pace, but again, just feel free to tell me I'm going too fast. So what is home care? I often get this question. There's a big difference between home care and private duty skilled care. There's a lot of organizations that say that they're home care, but they're not actually billing Medicare. And what I mean by that is those are private duty agencies. So you really want to be first off distinguishing what are home care services and what are private duty home care agencies. For us, we're billing Medicare, and it's typically covered at 100%, even with the common advantage plans that are out there in Michigan. I think Michigan has got a pretty significant increase in Medicare Advantage plans. So home care is something that's covered under your Medicare. When you're working with home care agencies, again, physicians are required to follow for orders. And what I mean by that is we have to update a doctor on really how you're progressing and how you're doing regarding your care. So if you ever work with a home care agency, they'll say, who's your primary care doctor? Who's your orthopedic doctor? Who are you working with that we can update? Our clinicians can call and actually update them on your progress. Depending on your diagnosis, your current status will depend on the frequency and duration. So those care plans are typically very individualized. And what I mean by that is somebody who is maybe being seen for physical and occupational therapy might really be focused on having PT out 3 days a week, as well as OT twice a week. And it could be for 6 weeks, could be for 12 weeks. While we have somebody who maybe has a wound or an ostomy, and they're on services for 16 weeks. So everybody's really individualized. And when you meet with a care team is really when they're going to really distinguish and identify the frequency and the duration of those services. Listed are kind of the specialty programs that we provide. This is not uncommon with a lot of home care agencies. So you want to ask, what are your specialty programs or what are you looking for home care? Physicians can order home care services for you. If you're coming out of a rehab facility, it's not uncommon to have home care services. And again, it's just vocalizing that you want the services and be able to provide those services in your home. And again, with the specialty programs, you get specific booklets and pathways and education for those type of education. So like for our cardiac partners, we're going to be providing really detailed education and booklets for you to really talk about your heart failure and what that looks like. The next slide is really talking about palliative programs that are out there in the community. So there's actually two types of programs. One's a little bit more common than the other one, but I at least want you guys to understand really which one, which are available and what those look like. So let's talk about the nurse practitioner palliative program. This one is very common in the community. So you have a nurse practitioner. Typically, there's always a social worker and chaplain that is provided as well too. The frequency depends on individual patient needs. And really, it is covered by Medicare. Some of the organizations accept more than just Medicare. They'll accept Advantage plans as well too, depending on the program. This is not the same as inpatient palliative or clinical models. This is in a home setting. So again, this could be at a nursing facility. This could be at an assisted living, an independent living, or it could just be simply at your home. So wherever you call home, this would not be in an inpatient palliative, very separate models regarding that. So again, you're having a nurse practitioner that's coming out to talk about your symptoms, talking about your pain, your nausea, if you're experiencing any of that, talking about advanced care planning. Do you have advanced directives completed? What does code status mean to you? What does do not resuscitate? What does full code really mean? And then talking about really your disease process. Where are you at currently? What does that look like in the future? What does it look like in 3 months? What does it look like in 6 months? And really kind of walking you through that diagnosis and really having those in-depth conversations. What I like about this model is it's really individualized. The nurse practitioner comes to your home. She could spend an hour with you. She could spend 2-3 hours with you. Typically with this model, you're seeing or communicating with the nurse practitioner once a month. And again, with palliative, you're still seeking treatment. That's the biggest thing between hospice and palliative, you're still seeking all curative measures. So whether that's chemotherapy, radiation, specific new trial medications, things of that nature. So you're still wanting curative measures. And so then you're transitioning, you're not yet ready to transition to hospice where you're not seeking those curative measures. With the nurse practitioner model, you're not having a skill need. And so what I mean by that is you don't have to have home care. You don't have to have any other services going on. You're strictly seeing a nurse practitioner. And again, typically there's a social worker for resources and chaplain. So depending on the program that's out there in the community. And again, who makes these referrals? Physicians typically make the referrals. It's not uncommon if you're in a nursing facility or an assisted living, they're able to make the referrals as well for you. So you just simply ask about those services. Palliative is a great program. Sadly, it's very limited. There's a lot of conversations in the community about making it more readily available. I think some of it comes down to cost and things of that nature, sadly. So the one that I wanted to refer to is community palliative. So again, this one is a little bit different. You're actually going along with home care services. So you actually have a nurse and a social worker that's cross-trained in home care and hospice. So we wouldn't be able to go into a rehab facility, but we would be able to go to an assisted living, an independent, or an adult foster care, because you're receiving rehab services. So you're getting the nurse and the social worker that are cross-trained to provide resources and support and talk about your diagnosis, but you're also getting PT and OT services as well too. So with this model, it's not as common. I believe there's 2 other companies that provide this model in the community currently. We don't provide it currently. I think there's conversation about that, but I know of 2 other agencies that actually provide this model. I like this model because I think it allows the staff to really have those conversations in the moment. When you choose to go hospice, I always want to make sure families are ready for that, right? That's an end of life conversation. So when we talk to patients, I always say, try home care, see how you're doing. How are you progressing? Are you ready for that next step, or are you not progressing? Have you continued to decline? And I think this allows you to have those conversations in the moment to talk about, we're trying therapy, but we're not seeing, mom progress or, dad progress. So I think it's just a matter of in the moment conversations and having that support from a clinical team as well, too. And they're going to have similar conversations that the other community palliative is going to have, right? They're going to talk to you about your symptom management. They're going to talk to you about advanced care planning and doing education with you. They're going to talk about goals of care discussion, and they're going to talk about the illness and the progression, but also providing resources for the patients and family. When I talk about advanced care planning, I want you to understand if it is such an important thing to have, because when you make decisions, you are able to make decisions until you're deemed by 2 physicians incapable of making decisions. So keep that in mind. Nobody is making those decisions for you. What's nice about advanced care planning is if you get to the point of not being able to make decisions and 2 physicians have deemed you incompetent of that, you have your wishes written down. I've been in this industry for about 15 years, and I've been in situations where sadly the patient had no documentation, family had no documentation, and because they were in a facility and without proper documentation, the family wasn't able to get guardianship. We had to, and they were on hospice, they're comfortable, but we had to send them out first in the EMS ambulance, and sadly they passed in the ambulance. And if I can advocate for anything, is to make sure you have your advanced care planning documents written out, giving that a copy to your physician or to the hospital of your choice so they can keep a record of it, because it is such an important decision. And it allows you to have a voice for yourself on what your wishes are. I've been in situations where families making decisions, even though mom or dad did not want any aggressive treatment, but their children are making those decisions for them. And it's such an important thing. I will talk about it at length today, but it is such an important thing to have, and I will continue to advocate for it. So just have your own voice, have those documents. Typically in the healthcare systems, I know St. Joe's and I believe U of M as well too, they actually have advanced care, kind of very simple patient advocacy forms available to you. And that's something that you want to at least have a conversation with your primary care as well too. And again, they get actually paid for those conversations. So keep that in mind too. So when you're going to your primary care and you want to have those conversations, make sure you're talking about that. And I'll talk a little bit at the end of the presentation about that as well too. So as we progress, we talk about hospice. So what does hospice focus on? Comfort, support, compassion for the patients, as well as the family and the caregivers along the journey. So we're really alongside for the journey of really what are your choices, or what is your family choices for your care. So how can we support you? How can we really answer any questions or have any needs that you have? How can we do that to the best of our ability? So you're kind of taking the lead in that, and we're following along that journey. If you're on hospice, it's not common, but it's not uncommon. We've had patients that want some training for physical therapy for their loved one. So we're able to provide a 1 or 2 visits from our therapists to help educate on, some transferring or exercises that we can do for, you can do for your loved one. And a lot of people don't know about that, but that's something that hospice is able to do. Hospice is covered under Medicare at 100%. So even if you have an Advantage plan, I know that's fairly popular in Michigan, it doesn't matter. It's covered at 100%. What hospice does not cover is 24/7 care. And this is where private duty would come in, or placement, things of that nature. And it does not cover room and board. When I talk about room and board, it's typically in a facility. There are rare policies out there for room and board coverage. It's called 5th level benefits, and that actually covers it. But typically our patients either are paying privately for room and board, or they're applying for Medicaid for that room and board coverage if you're in a facility. Now, there are some hospice facilities in Michigan. I did list them as well too. So there's a few of them here. There's about 4 of them, and it talks about the cost that's there. So, and these might be adjusted currently. This is the most recent data that I had. So I apologize if you know differently than me. But with the facilities, they're typically admitting, and then they're looking at either, they do have some Medicaid beds, and then if not, they're looking at private pay. And those are conversations that facility would have with you as well too. It's not uncommon to see patients that are kind of very acute in these types of settings. So when I talk about that, it's shorter length of stays within those facilities. So if you're looking at a longer prognosis, so with hospice, they talk about 6 months or less diagnosis. If you're living kind of almost past that point, they look at either paying privately or looking at maybe transferring you to a better setting for yourself and your family. So keep that in mind as well too. What does hospice cover? So it does cover supplies and medical equipment. It does cover medications related to your terminal diagnosis, and any secondary medications are covered typically by that secondary insurance. When people, and we'll talk about myths here shortly, but medications, we're not going to just stop your blood pressure medications. That would lead to discomfort and pain, and that's not the goal of hospice. What services are provided, I'm listing those as well too. Depending on the program, there are some more specialty programs. And again, these are conversations you want to have and with the hospice agencies. And I encourage families to shop around. And what I mean by that is look for a hospice that is going to be good for you. Home care and hospice benefits never go away. There might be more limitations with home care, but hospice never goes away, that benefit. So you could be on hospice multiple times with different agencies, but pick the one that's right for you and your family. It is something that Medicare does cover, and it's really finding the right program that works for you and your family. And understand, if you're not happy with the agency, it is okay to transfer services. It's no different than with home care as well too. And I think that's something important to keep in mind too. And when you're looking for hospice or home care agencies, if you go to Medicare.gov, I use it myself as well too. It allows you to compare agencies. So with home care, there's actually star ratings from Joint Commission. So they'll actually star rate the home care agencies for you. Hospice does not do that, but they actually provide surveys to families following their care. So they actually give you that data. And I find it so important to be able to research what works for you and different agencies and really be able to say, maybe the conversation was great, but their data that they're providing, are they out within, the last 48 hours of care, maybe is poor. So those are things to look at. And so it's such an important website to know and to keep in mind when you're looking for home care or hospice agencies as well too. As we talked about, therapy services is provided as well too. So typically it's 1 or 2 visits, respite stays. And what I mean by that is Medicare leaves it very gray, and I love that they do. What's nice about that is it's for rest and reprieve for the family. So if you're living at home and you're taking care of your loved one, it allows for the social worker to help organize and coordinate a respite stay at a facility. So depending on where you're living, it's working with the nursing facilities in the community, and it's 5 days of respite. Depending on the needs will depend on the frequency. So I've had families use it twice a month. I've had some families use it none. I have some families that use it once a month, and it gives them that ability to have that rest. I've seen it used to where they're able to kind of trial to see if that facility is a good fit for their family, and it's still covered under Medicare for 5 days. And then they can gradually transition to long-term care if that's appropriate at that moment. And so it just depends on what works for you or your family. So the next kind of couple slides talks about those common myths and questions to ask with your physician. So the first one is hospice means giving up hope. Hospice is a shift of care. And what I mean by that is, if you think about it, when you're going to the ER, you're looking for treatment, right? They're going to prick, poke, x-rays, MRIs, everything. That is what the ER is meant for. That's what the hospital is meant for. It's for curing and healing. It is not common for patients to pass unless it's in very immediate in that moment, that they're going to pass in the hospital. That's what it was before. That's what hospice was. It was going to the hospital and passing comfortably in the hospital. The hospitals have really shifted from that. The hospitals are more focused on curative measures. So it's just really changing that focus on what matters for that patient and really focusing on that comfort and enjoying that time with your loved ones. And the second common myth I often hear is hospice patients stop all current treatments and cannot return to medical treatment designed to cure disease. I have met with families, like I said, I've done this for a long time. I have signed consents with family members, and I tell them, if you change your mind that evening or within an hour or the next day or in a week, you have that right. It is a benefit that doesn't go away, and you have the right to seek treatment. I personally never want somebody to make the decision to go on hospice and not be 100% comfortable with that decision unless they're ready for it. And so if you say that you want to seek treatments and you want to go back to curative measures, absolutely. We want to respect you on your journey and where you're at. This is not uncommon either when we have patients that have fractured, they've fallen at home, they fractured a hip. What we'll do is, it's not uncommon to take them off of hospice, let them have surgery, right? Because they're in so much pain. We don't want that for patients. No hospice does. So what they'll do is they'll discharge, have the procedure, do the reparative measures, get the patient comfortable, and then go back on hospice and go back home. So that's not uncommon either. And again, if we've had patients that have cut their arms, we just become that 911, and you'll hear that often with hospices. We just need to be notified about it. We'll meet you at the hospital, make sure if we can't stitch you up, we'll send you to the hospital and then send you back home. So it just really depends on what the situation is, but it's, again, communication with your hospice company that you're working with. Hospice patients are automatically discharged if they live beyond 6 months. And this is what we talked about earlier. 6 months is just a Medicare guideline. What happened a long time ago was patients had dementia diagnosis, and they were on hospice for 6 years, 7 years, 10 years. So Medicare learned to kind of set some limitations. So it's just really a matter of recertifying and having a physician verify that your disease is still progressing and that you're still appropriate for hospice. I have had patients that actually have graduated from hospice. They tend to, it's not common. I mean, it's a small percentage, but because we're addressing their pain and their symptoms, it actually improves their life. And because they're not focused on the pain and the symptoms, they're actually enjoying life, and they actually improve after some of the medications are adjusted, and the patient's actually able to enjoy life. So that does happen. Now, is it rare? Yes. But again, that physician is addressing that in the moment as well too. Hospice is only for patients who live a few days to live or are actively dying. Again, as we talked about, it's a 6-month benefit. So I believe the national average right now is 37 days. It's the average length of stay. So most patients that actually receive hospice benefits don't actually fully even utilize those benefits. So that is not something that often happens. So myth 5, patient will die sooner on hospice. And this is what we just talked about on the previous slide, but there was actually an article in the Journal of Pain and Symptom Management. It compared patients that had CHF within a 3-year window, and actually it noted that the difference was an increase in their life by 29 days. So actually patients lived longer on hospice versus non-hospice patients with congestive heart failure. So that's a pretty significant amount of time. And I think when we talk about that, people kind of are like, what do you mean you can live longer? Well, you're not focusing on your pain and your other symptoms. You're actually able to enjoy life. You're actually able to do the things that you want to, whether it's with your family, traveling, things of that nature. You're able to focus on that versus focusing on the pain and the symptoms that might be occurring because of your illness. Myth 6, you must be a DNR in order to receive hospice care. So when I've met with families, it's not uncommon within hospice to talk about a do not resuscitate. You do not have to sign that when you first start hospice. If it's a matter of, I still need to talk with my family about this, I want to make sure they understand what my wishes are, that's not uncommon. Now, the conversation doesn't stop, but you can be a full code on hospice. We've had that just in the past few months. Patient was still a full code, and they ended up having to call EMS. They attempted to resuscitation. The patient passed comfortably, but they were a full code on hospice. And, that's a matter of what your wishes are. And every organization should respect that. So the conversation doesn't stop, because a lot of times we find that it's just a matter of education and understanding, what does CPR mean? What does do not resuscitate mean? What does full code mean? And what does that lead to? So a lot of it's just conversations that we just continue to have with patients and families. As we talk about CPR, I thought this was an important slide. This was actually from 2014, but it's quite recent, and it talks about what CPR and what you should know. So most people don't realize CPR was intended for a healthy 25-year-old. So I wanted to at least kind of show some data regarding CPR in the hospital, CPR out in the community, and what the average outcome is having CPR done to you. So adults with serious illness who get CPR and live, at most 15 out of 100 leave the hospital and may live an average of 4 months. So it's pretty significant data. I always encourage patients and families to talk about, what does CPR mean and what happens to my body if CPR has to happen. And I think a lot of it's just, again, having that education and conversation with your physician, and talking about what can occur once CPR is done. So CPR outside of the hospital, 5 out of 100 leave the hospital and may live up to a year. So living in the community who get CPR and live, and then adults living in a residential setting who get CPR and live. 2 out of 100 leave the hospital and may live up to 1 year. So that's pretty significant data that I think is important for everybody to know and be educated on. So the next slide is really kind of talking about key points to talk with your physician. So again, do you understand your illness? Ask your provider questions regarding all of your healthcare options. Again, when you're making that decision to go with hospice, I cannot reiterate, making sure you're at 100% comfortable with that decision, and really asking all of the questions and options that you may have out there. Write down your questions and concerns prior to your appointment. Discuss specific treatment options. Oh, I was online, I researched this. I think we all do that. Is this an option for me? What does that look like? And having those conversations. And again, your physician gets paid for these conversations. So I always like to tell my doctor, I'm there. I'd like to use my time at fully, and they get reimbursed for this. So I think it's important to know that if you're with your physician and you want to have those conversations, talk to them about that. And again, they can get reimbursed for these too. So it's not a burden to them. That's what they're there for. I do find some physicians are more comfortable with these conversations than others, but that's where, you're an advocate for yourself and nobody else will be. And I think that's such an important factor to keep in mind too. Set up follow-up appointments if there's something that you don't understand. And ask yourself, what does living well mean to you? What are some of your fears or concerns? Discuss that with your physician. Mention any religious or cultural backgrounds in your discussion. If there's things that you've experienced or you grew up experiencing, or maybe just don't fully understand, talk about that with your physician. Those are important things for your doctor to know as well too, what your wishes are, and they'll document that. So again, having those advanced care planning documents is so important, because again, they will not become active unless you've been deemed by 2 physicians that you're incompetent in making decisions for yourself. But you want to have your wishes written down. I've had that conversation with my husband. He's like, well, I want to be in the cemetery, so I want you there. And I said, but that's not what I want. So we would argue about it. I'm like, this is not an argument. This is who I am. And so to a certain point, I had to make sure my wishes were done, and I did them in my early 30s. Again, I've done it. I've been working in this industry for a long time, so I know the importance of that. But even just having conversations with your family, even if it's side conversations or at the dinner table, oh, this is what I want. I just want you guys to be aware of, even if you maybe not have them written down and you maybe put it on the back burner or I'll get to it eventually. I think even just vocalizing what those wishes are, just so that way they at least know, is important if you don't get to them. But again, like I said, I wrote mine down because my husband would do whatever he chooses to do. And I'm like, I'm not okay with that. So for me, it was important to make sure that my voice was heard in what my decisions are. So just keep that in mind too. And the last one, what if my heart stops? And what we talked about previously, what is CPR? What is a feeding tube? What is a ventilator? What does that entail? How does this affect me? Ask those specific questions. I used to work at a nursing facility and we'd have these conversations and they're like, well, okay, give me 2 breaths and then pound on my chest 3 times. And if that doesn't work, just stop. Sadly, it can't be that way. It's either we attempt CPR or we don't. But it's like, what is it that you're not understanding about that? And what does that truly mean to you when you're having those conversations about your heart stopping? So I think it's just a matter of really understanding CPR. What does a feeding tube mean? What does ventilators mean? And I think that as a provider or anywhere you're in any type of healthcare setting that you're at should be able to answer those questions for you as well too. Even look online. There are YouTube videos, online videos from healthcare sources talking about what does CPR do to your body. Those are important things to actually see as well too, or at least read through and understanding what that truly means. So that's kind of what I have for presentation wise. I apologize if I went too fast. But I'm very open to any type of questions, and I'm actually pulling them up right now. Yes, so AG, the PowerPoint slides will become available after the session. Absolutely, that won't be a problem. I'll send it over to Jennifer as well too. So describing the CPR procedures and the after effects. So typically what I think it's something you need to discuss with your physician, and I'm not a physician, so I don't want to speak to what I don't know. But it's not uncommon to see ribs that are broken, multiple. Again, when CPR was created, it was created for 25-year-olds, healthy 25-year-old. And so there's significant damage that happens to your body, fractured ribs. You will then possibly be put on a ventilator to assist you to breathe. And then that leads to feeding tubes to help you thrive. So those are just a few of those items. Again, I'm not a physician, so I don't want to speak incorrectly of any other things or the after effects of CPR, but it's not uncommon to have fractured ribs, cause other damage to other organs. And then it's also not uncommon to have then at that point be put on a ventilator. And then when you're on a ventilator, you're not able to feed yourself. So then it leads to being put on a feeding tube as well too. Hopefully that answers your question, Margaret. Is there any other questions that I can answer for people? Sorry, Ryan, I jumped right into it. I know you're.
Oh, no worries at all.
Okay.
All right, well, if there's no other questions, we'll go ahead and end the webinar. This was recorded, and so we can share that with you all at a later date. All right, well, thank you so much for joining us this morning, Yaza, and really appreciate all the information that you gave us. All right, everyone, well, have a great day, and if you have any questions, just reach out to Turner, and we will get this information over to you. Thanks so much. Bye-bye.